This week, IHI's president and CEO Derek Feely penned a blog to coincide with today's discussion about the impact COVID-19 has had on community of colors in the U.S. And here's a piece of what Derek writes. If there is a silver lining in the pandemic, it may be the opportunities this unprecedented challenge has presented to us. In every decision and action to prepare and respond more effectively to the new realities facing us, there is opportunity to build new systems and structures with equity as a crucial component. If healthcare moves to right past wrongs, perhaps other parts of society will follow. That's unquote. So that's the challenge staring health systems, communities, public health policymakers, and leaders of all sorts in the face right now. It's not the first time staggering data have exposed long-running health and socioeconomic inequality in the U.S., but what COVID-19 has wrought and revealed anew is where we're going to dig in for the next hour with help from our panelists and all of you. We welcome three outstanding panelists to the program. Doctors David Ansel from Rush University Medical Center, Ron Copeland from Kaiser Permanente, and Tony Lewis from Liberation Health Strategies. And we welcome back IHI's Don Berwick and Derek Feely as our regular expert panelists on these virtual learning hours. So, hello to all the panelists. Thanks for making the time to share your expertise and perspective with us. And hello to everyone joining us. As usual, you're going to hear from our panel for the first 35 minutes, and then we're going to turn to Q&A and discussion. Feel free to chat in questions and exchange ideas throughout our hour together. Just be sure to chat to all participants so we can all take advantage of your thoughts. And we're going to start with some framing and perspective from Derek Feely. Derek, we've been discussing equity throughout our series on COVID-19, and today we're turning up the volume even more on this subject. So what are your thoughts to kick things off?
Well, thanks, Madge, and good morning, everyone. I called that blog that you referred to, we titled it Tragedy and Opportunity. And let me explain why. First, the tragedy. The statistics that we can see in this first slide here are alarming and heartbreaking. When Louisiana first published its COVID-19 data stratified by race, this is back in early April, we learned that African Americans accounted for 70% of the deaths, while making up less than a third of the population. Similar numbers in Chicago, from Michigan to Mississippi to Brooklyn, black people are more likely to get sick and more likely to die. There are also significant adverse events for Latinos and Latinas, for Indigenous people too. And this is not just a US tragedy. I suspect we'll focus a lot of our attention today on what's happening in the United States. But if you look at this last slide, I saw this data from the UK just yesterday. And it shows that black people in the UK are 4 times more likely to die from COVID-19. And I would urge everybody to go and look at this Office for National Statistics report, because I think it reveals quite a lot that we might apply to our thinking in the United States, because in the data, ONS, the Office for National Statistics, goes on to just lay bare all the usual excuses. And so in the data that underlies this, they adjust for income, for socioeconomics, for health status, and the gap is still double. So still a set of issues that are to do with how people of colour are able to thrive in that country, and I suspect many of the same things apply here. COVID-19 didn't create these injustices, they already existed, and indeed we've long seen them in things like maternal outcomes, for example. But it has cast a spotlight on inequity and injustice, and that, I think, Madge, takes me to to the opportunity piece of this. That's the first opportunity. This is front page news. And the first step to solving a problem is acknowledging it and naming it. And therein lies an opportunity. And second, there will be no return to pre-COVID normal, and we shouldn't allow that in any event. Now we get a chance to build new systems and new structures with equity at the core. Now we get a chance to acknowledge that systemic racism and implicit bias compromises care and health. And in order to do that, we need to see what's going on. We need to listen to the people who are affected, and we just can't let this opportunity pass. It is tragic. The numbers are shameful, but all the more reason for us to take this opportunity to course correct, to make the new normal fair and equitable and just. Thanks, Madge.
Okay, Derek, thank you very much. We're going to now have the panel lend their wisdom to, I carved out 3 areas that I thought would do our best to tackle. One having to do with the data that is kind of ricocheting around the country and the world. What immediate actions might be taken? We are in the midst of things after all. And what needs to be done to hardwire some changes for the longer haul? And we're going to do our best to get through all of this, but we promise we'll also get to your questions and comments, and we'll weave it all together. Don Berwick, asking you to sort of start with some of this data that Derek has just shown and your own view of data. And how might we... I've been interested in a lot of the articles that are also trying to guide how we're understanding even what the data are telling us. So why don't we start with you, and then I'm going to bring in others. Thanks, Don.
Thank you, Madge, and thank you all for joining us. Maybe I'll start with one edgy comment, which is how limited the data have been. I was very struck that as we began to see these racial disparities in outcome, how few states were stratifying their data according to race. That's changed over time, but we can't deal with what we can't see. And unfortunately, these issues, which are driven by structural racism, as Derek said, have been hidden far too much. That said, we know the disadvantage that communities of color and people of low income in this country stand at. And COVID-19 is revealing what has been there all along and will be there long after COVID-19 is gone if we don't begin to face up to this. The causes are multifactorial. They're structural. I want to say it will be a mistake to deal with this only as a short-term problem in addressing these shocking disparities in outcome for COVID-19. We must do something in the short term, addressing these issues right now and figuring out how to restore some equity to outcomes and care is crucial. But I agree with Derek. If we don't deal with this as a structural issue and get to some of the roots here that lie deeply in the history of this country, we'll be missing an opportunity. This slide makes a point that I wanted to add, and this is for people of color and people of low income in this country. This isn't just about COVID. It's about the whole disadvantage in society as a whole. I found this this graph produced by the Massachusetts High Technology Council last week of job vulnerability in Massachusetts. These are people who can and will lose their jobs in this enormous recession. Notice the relationship between job vulnerability and income band. So people at the lowest level of income, 76% of them risk losing their jobs right now. Those of us in the highest levels of income our jobs are not at risk. This is also structural, and it also goes along racial and socioeconomic lines. There was an article this morning in the New York Times, Nick Kristoff's column, which talks about Denmark. and what it's like to have a country that is committed to social justice, equity and redistribution of wealth as a matter of policy, and what that's doing for security and well-being in that nation. They are not exempt from the issues of racism, but once a society commits to solidarity and acts that way, things really can change. I hope we do. I can't wait to hear the panelists match. Thank you so much.
All right. Thanks, Don. All right, Ron, the order is only my attempt to just kind of mix things up, but let's start with Ron, then David and Tony, and any thoughts you'd like to share about data, that being our theme just as we get going here.
Well, thanks, Matt.
Yeah, great.
Okay.
Yes.
I think the data question is a critical part of this conversation and any actions that we choose to take in the future. Thinking about our own journey at Kaiser Permanente, data has multiple purposes. One is to create awareness, to the point Don made earlier. You can't evaluate and act on what you can't see, and it's hard to see what you can't measure. So it has the awareness and the availability of insight, but it also has to serve as an opportunity for improvement, and it also creates transparency that allows you to evaluate your actions against what you discovered, and therefore hold individuals and systems accountable. I think our challenge at looking at this on a broader scale across our country is the fragmentation of our care delivery systems across the country makes it not impossible, but nearly impossible because of the effort required to synthesize meaningful data collection. It's a challenge for individual systems to see their populations and what those data show for them and where their opportunities are. Private and public data that can be integrated and a system or a community-wide approach can be used to try to close the gaps and address the feeders. We've been spending a lot of time over the last several years, not just understanding and being aware of the role that social needs play, but actually measuring them within our own population, collecting data from our members and patients, and matching that with public health data in the local community to create opportunities to partner with others, systems in the community to have a scalable, positive impact, as well as to identify our opportunities to manage people in a more effective way. If you're managing a system and a population as a whole, then your data gives you the kind of individual and global insights you need. But if you're just doing transactions one patient at a time and you're not looking at the whole picture, it's very easy to miss these trends. And then we know the structural racism and all the forms that it takes. That's been documented over and over again with many, many comprehensive reports. So data is important, but data is not a substitute for the moral and political will to make a difference, which I think is anchored on at a core level. You value all human life or you don't, or you value some.
Thanks, Ron. Okay, let me shift over to David, Ansel, and Rush and the Chicago area. And maybe, David, I'll just add to the query about data just right now, whether data has helped inform any of what Rush has done in the midst of this crisis. Thanks. Oops, do we have David? Did we lose him? David, we're not hearing you. Let's make sure. There you are.
I'm unmuted now. Thank you, and thank you for inviting me to participate. I would just second what Dr. Copeland said. We have enough data. It's action that's been lacking. None of this should be a surprise, as horrific as it is, that these data layer in a way that, as could be predicted, with white on top and black and brown on the bottom, and it's true in the United States, and it's true in, as we saw Derek's presentation, in other countries as well. So data is important, but it's really important to think about action. So a few years ago at our own place in Chicago, and I would also agree with Dr. Copeland about the need for taking population approaches versus individual approaches to this. We changed our mission at Rush to improve health, as most places did. We are a small health system, but located on the edge of on the west side of Chicago. And we appreciated these giant life expectancy gaps, presented it to our board, that 3 stops from Rush, your life expectancy it would be as if it was the United States in 1950. And yet 2 miles to the east in the Loop, you could live to the highest life expectancy in the United States. We brought this to our board and said, if we're going to improve health, we have to address the conditions in the neighborhood, particularly the social and structural conditions, and name racism and economic exploitation and other afflictions as the root cause for poor health that we were seeing in our patients. And a big part of this was to say that we, as an institution, largely a white institution, that been around since the beginning of Chicago, had a responsibility, if not an accountability, for the conditions in the neighborhoods. And then we went out to the community to talk about this and suggested that we partner with the community. And we got the other hospitals in the area to do that. And we created something called Westside United, and with the idea to address the social and structural determinants of health by not just addressing health and healthcare, by being population-centric, these neighborhoods that we looked at 550,000 residents, insurance and institutional agnostic. So what can we do around health and healthcare delivery? What can we do around the physical environment? What can we do around education and economic vitality? And we created an entity as the leadership is community residents partnered with hospitals. The power decisions, the decision about how money is going to get allocated, and the decision about how resources are getting allocated are being made by the community with the hospitals. That took a big leap for the hospitals to do something like that, but we did it, and we just had on March 5th. Our 3rd annual meeting, in which we put together a strategic plan for the next 1,000 days in the lives of all West Siders in Chicago. It was like, imagine what the next 1,000 days, 3 years about could be. Obviously, the first 3 years of life are so important to children. How could they be in everyone's life? And we've been very active doing things. So if you just, at the bottom right, you say, last year, 1,700 jobs to West Side residents at our institutions. The mayor in February announced impact investing with the AMA that we did on the west side of Chicago. Go back to the last slide for a second. Internships, small business grants, career pathways, doing all the things that we can do to address the structural nature of this, getting businesses off our supply chain to move in the neighborhoods, really trying to leverage what was a good economy to get people to invest capital, because capital has been removed from these neighborhoods and is the underpinning deficit that's occurred. And we are saying, how can we bring capital back? Real capital, human capital, social capital back to these neighborhoods. And then COVID hit. Turn to the next slide, please. And the mayor, seeing the excess black deaths, by the way, Chicago has the largest black-white death rate gap in the country, 9 years. Every year in Chicago, 3,200 black people die in excess of white people. And that's been true since 2009 when we first started looking. That's a 9/11 every year in Chicago. So there's been an ongoing disaster. And this structural approach was, let's take on structural racism, starting with the West Side. But when COVID hit, the mayor said, we need to take action. It's unacceptable. It's horrific. And put together a group and then reached out to West Side United to say, how can you partner with the city to address racial inequity? And so what's happened in the city of Chicago, that part of the incident command center for the city of Chicago is this racial equity rapid response group. As I say, this has to be long-term response. It can't just be rapid, but there is a rapid response group. It has 4 subcommittees. There's a provider subcommittee that I co-chair with Dr. Selwyn Rogers from the University of Chicago. There is a data subcommittee that's being co-led by our West Side United data folks and supported by with the health department. There's a community subgroup that have leaders from community-based organizations who are telling us exactly what they need on the ground. And there's a communication subgroup. And we're doing things like looking at what is the testing availability in the neighborhoods, looking at how this epidemic is rolling. Right now in Chicago, Latino cases are outstripping Black cases. And this is just over the last few weeks, and that mortality will likely follow. But we're putting together action plans to say how can we address COVID. Right now, there's a big move, like in Massachusetts, to hire about 800 community health workers to do contact tracing. There are teams working on homelessness and the problems of the outbreak in the homeless and in nursing homes. But it's in lockstep with the city's command center.
Thank you, David. Okay, so what David did is he kind of went from data to some immediate action. So Tony, come to you, Tony Lewis. Thanks again for being part of our discussion. It's a real pleasure to have you. Feel free to comment on anything about data perspective there, and I'll let you kind of migrate us into some of the immediate kinds of steps either that you would promote or have witnessed. David sort of got us going on that. Thanks, Tony.
Absolutely, and thank you guys for having me. It is a little bit of a thing being a family doc and geriatrician in the epicenter. I'm in Bed-Stuy, Brooklyn, New York, and practice both with individual patients as well as do national and global strategy. So I want to back up a little bit to the data because I appreciate Derek's framing of us needing truth, and the framing that Don gave us in terms of the data surfacing. But I think if we look at the role of power, politics, and culture as to why that data wasn't there in the first place, that's I think it's a really significant kind of overarching theme in terms of all of our work, because you can look and see that there was an actual push around mid-March by a bunch of Black doctors and professionals to call for the data, because we had heard from the ground between clinicians that were working in communities, especially here in New York and all around the country, that there were more Black folks dying than what was being reported. And we started looking at public health departments around the country and seeing that data wasn't being reported. And after we listened to and talked to many individuals, we found out that there were 2 reasons. It was not being reported for fear of being seen as not serving communities or being racist. And it also wasn't being reported because folks were fearful that once the data came out, that maybe there would be a militarization like you're seeing now in New York. So I want to just point to that like this data, this truth, this hard truth of the country, that operational and institutional racism is in the fabric of everything and threads through everything we do, and is powerful and will kind of stop us from progressing if we don't push back on it with our power, privilege, and access is a key thing. So you can look and see the article in 330 with myself and my partners at the Health Equity Cipher with Dr. Joya Correa-Perry, Siobhan Arline Bradley. You can see the article in the New York Times by Aletha Maybank at the AMA on 4/7. And then actually on April 6th, to talk about the global perspective, a couple of years ago, I co-founded with Global Partners of African Descent, this institute called the Global African Workers Institute, partially in response to the fact that folks of African descent around the globe were far behind in not being seen or served well in the Ebola epidemic and many things we were seeing globally. And on April 6th, which was World Health Day, there was an article put out by Baba Aye, who's the health officer for Public Services International, which serves 30 million workers around the globe in 154 countries, that said we have to break the cycle of panic and neglect, because moving from data to action requires that we have data and use all of the things we know, because many of these techniques, and I really appreciate the presentations about pouring into the community, about putting, lifting up jobs, about engaging the voices. Those are all amazing practices. Um, and this is information that we had prior to this becoming a pandemic, and we needed to act then. So, like, how do we act now, with the data that we have, and continue to push with the power and privilege and access that we have to address both the kind of repercussions of starting late, So there's mental health issues and trauma and all of these things that's going, which is really the biggest calls. The most calls that I get now are folks dealing with multiple types of grief, fearful of the police, worried about losing their job, worried about losing their home. So, like, definitely a pitch for, addressing those issues. And then the basics of, like, shelter and food and dealing with, like, our policing. Like, it's not a surprise. Today is Ahmed Aubrey's birthday. And you all might have seen this video of this man who should be 26 today, who was jogging in Georgia, and was hunted down and murdered. Now, to be clear, like, the same power, privilege, and culture that hid our data hid those videos. So, like, I just need to kind of pull that back to Dr. Mary Bassett's article in 2015 on Black Lives Matter and why we as a medical and health community should get involved in all of that. If we don't address all of those things, then we will just be kind of chasing our tails with, like, little bits of things. So those are kind of my initial kind of thoughts. And the action steps really are rooted in, like, some of the great techniques that David lifted up from. So, like, my aunt was a social worker in the west side of Chicago for about 30, 40 years. So I was studying the math. I'm like, oh, that's where my auntie was, Tony, who I'm named after. But, like, those basic kind of just community, just ask and understand and recognize the expertise of people. And yes, pour into folks in the community, and not just, let's not task force or volunteer this to death for folks who are already carrying, like, so much of the burden of having this disease attack them mentally, physically, and spiritually.
Thanks, Tony. I really, despite my, you can see how my three chunks, in some ways, they're all interrelated, and I appreciate always when panelists basically make better sense of it maybe than I did in my outline. I wanted to turn to Ron Copeland, and I guess kind of crisscrossing through these areas about data, immediate things that are possible with COVID-19 and long-term, some of the things, again, that Tony was just referring to. Would you say that the work that Kaiser Permanente has already done in this space has helped in the response to the pandemic in ways that maybe a lot of health systems on people joining the program right now still aren't sure quite how to get the traction that maybe Kaiser has so far? So, Ron, could you speak to that?
Our integrated model of providing coverage and care simultaneously and managing our individual patients, but at a community and at a population level, gives us and has given us a long-standing set of insights into the role that social needs, structural racism, the housing, the homeless, the food, and so forth, that all those elements are part of a system. So I say that to say there's a leadership orientation and perspective on what health is, what drives health, what disrupts health. And then there's the ability to take that understanding based on research, based on observation, and frankly, based on input from our patients, the voices of the people that we're trying to serve, so that they give us the insights as where there's opportunity. And it's a funny thing. Usually we think about problems in one page and solutions in another, but our orientation is the source and identification of problems is also the source of solutions. So the people you're serving are your best agents for helping you understand what solutions, what powerful impact looks like. So I want to emphasize that bi-directional communication and collaboration with people you're serving, both in decision making and identifying opportunities. But even with all that, the real opportunity is, can you systematically impact at scale the factors that are driving and disrupting people's access to a total health and their mental health and so on. So yes, our ongoing definition of health, which we refer to as total health, mind, body, spirit, and knowing that your lived-in ecosystem and environment has more impact on your true comprehensive health than the interactions that occur when you come into an office or a hospital and so forth. That has given us great insights that we are absolutely leveraging during this crisis management for our own patients, but also leveraging the tremendous relationships and companions that we have in the community that we work with on a regular basis. And so as this kind of pandemic occurs, we're able to leverage those relationships to find solutions, to marshal support, and to have support brought back to us. And so the point that Dr. Lewis made about data not being visible or available because of fear of what it would say about an organization's reputation or create concern, that visibility on an ongoing basis really diffuses that concern if organizations are thinking that way and working that way on a regular basis. And I think that really boils down at the end of the day to leadership. But the other thing I would say is in our work over the last 10, 15 years in the health equity and disparity space, we've integrated our thinking and our motivation in this space into our quality improvement requirements. Because I think the data and information has to be put to work and building it into the same framework of quality improvement with accountability, with measurements, with incentives and investments. That's what's required to normalize doing this type of work and addressing these gaps on an ongoing basis and defining that as core in providing healthcare, not some extraordinary or situational focus for a few minutes and then moving on to something else. Now, a lot of my colleagues around the country, as we engage and talk with them and share learning, will say that that's some unique opportunity because of our integrated model, and that's a very difficult model to imitate or to duplicate. But I think there's the old adage where there's a will, there's a way, and the privilege issues, the mindset of scarcity that this is a zero-sum game. So if we marshal resources where it is most needed, then that means somebody else who has them are going to be deprived as opposed to what we can do together. And understanding that lifting all people up is the real opportunity here in the long-term play that we should be pursuing. I think that's a mindset, and that's probably the most resistant of this work. And data won't change that in and of itself. This is really about accountability. And to Dr. Lewis's earlier point, this is about the people have to rise up and push back against that mindset and invest in and support leaders who will take these issues on a daily basis and not just wait for a crisis to occur.
What I'd like to ask each of you, if you want to just weigh in before we go to the chat and some of our questions here, and thank you very much, Ron. So a lot of the articles I think many people have been reading, some of in major, thanks Rachel for that slide, in major media outlets in particular, you have scenarios where the underlying issues, of course, are always there that make many communities of color just that much more vulnerable in this pandemic. And then you have issues, the stories of people not feeling heard, not being able to get tests, finding themselves kind of dismissed in certain ways when they're trying to actually speak to somebody about symptoms. There's that very individual thing, and then there is to what degree people of color and other communities are on a lot of the committees that are formed and task forces, et cetera, making some immediate decisions now, not only about supplies and resourcing, et cetera, but also reopening. And what kind of relief. So maybe I'll just quickly go to Tony about that. Some of your thoughts on that. I know those are kind of big. It's a big swath. And then David, and then we come back to Ron quickly. Go ahead.
Sure. So I love tying all these things together because it really kind of all comes down to, whose voices, bodies, and experiences do we value? Whether it's in terms of leadership equity, diversity, and inclusion in terms of who we've got at the table making decisions or helping to advise on where things should go, or listening to communities, in terms of what's actually best in terms of addressing transportation. Like, who knows better than someone who's got to take two buses, a train, and walk a block, what their challenges are in getting to work and getting home when it comes to physical distancing. But actually, even that nuance you mentioned, that case with the patient who is not being heard. And this has become this has been in our popular media as we discuss maternal mortality before this, in terms of the Serena Williams story, the stories with Beyonce. All of these folks have come out and said, no matter how much money I had, the fact that I was a Black woman, I wasn't listened to. But I would let you know that, like, as a physician who trained at Georgetown University in Washington, D.C., and who trained up here at St. Vincent's before it was named several other things and eventually closed, that, like, even how we teach students, like, a lot of my colleagues have the experience of being taught how to talk to and listen to patients. And on their first set of rounds, going in and standing outside of a room and being told that the Black woman in the bed, she's okay and she's going to go home, but she might complain about pain, but don't worry about that and keep moving. And then we get to a white patient who may have more money and access, and they're taught to go in and dig deeper into the history and learn a little bit more and investigate. So there are ways where systemically we can start training all of our healthcare professionals differently, and we can correct things that we see like that. Because I have horrifying stories from my patients, friends, and colleagues about how they literally had all the symptoms, went back and forth, 2 and 3 times to different systems. And unfortunately, some folks, passed, transitioned, died because of that neglect. So it's all kind of, if we're doing all of this with an equity lens, it's understanding that, part of our culture really likes to skew compassion and competency, assume compassion and competency towards mostly white men, and white women sometimes. But, there's a spectrum. You can imagine this. Jonathan Powell out of the Haas Institute has a great diagram. I love diagrams, but that whole thing. And that, assumed lack of competency and disdain, or neglect, is assumed towards, Black and Indigenous and Latino populations. And so an equity lens means that we are, maybe we go with medical ethics and not doing any harm and doing good and being equitable and autonomous. But, it's really just looking at everything like, whose voices do we need to hear? Are we truly valuing them? And then making sure that we invest and move accordingly. Because one of the other things that's happening in this particular moment is, we are at a moment in our history and our culture where we're having to choose kind of, are we on the side, do we want to be on the side of history that moves towards equitable health, or are we kind of stutter stepping and kind of creating worse problems? And communities are looking and watching and seeing what all big institutions are doing, because we know what we feel and what we've seen over the last 6 to 7 weeks in terms of what it feels like to see that you're more likely to die as a Black woman. And we know that there's power and money and data and research that can do differently. So now we're watching to see if you can hear us. Because partially in New York, there was a decrease in the number of admissions and showing up at the hospital because folks in communities just knew they weren't going to be seen. It was like, forget it. And as a family doc, I wasn't going to send my folks to sit in a waiting room and get half a nebulizer treatment and then, be anxious and then, potentially deteriorate. So, think about those big frames in terms of who we value, whose expertise we value, and then pour into that with our power and privilege and investment. You're on mute, Madge.
Yeah, thanks, Tony. And your last comment there also is another way we need to get behind data. Why are numbers decreasing, even what you said? All right, the people in the chat are probably going to kill me, but I'm going to ask very quickly, David, if you could do this sort of fast. Maybe we could bring in, I think some people are looking for examples, and of course, the opportunity. People are challenging white allies, big white institutions sometimes, and others to step up and to demonstrate. And it was great to see the infrastructure that Rush has created. has that enabled you to do some of what Tony is talking about?
Well, thank you. And let me just start with the fact that that all COVID did was take the covers off of the social fault lines and historic racism, structural racism. I will point out W.E.B. Du Bois in 1900 said the problem of the 20th century is the problem of the color line. And of course, he did that famous study of health in Philadelphia of Black people, which is very well worth reading. And to this day, it still is the problem this day. And then when you take a crisis, whether it be a heat wave, a Katrina, or COVID, it's just going to magnify those things. So implicit bias. I've had conversations with the community members of an ambulance showing up at a door of someone's house and not taking them because they don't think they have insurance. This is city ambulances. So the deeply embedded structural and perpetuating systems of racism, they are self-perpetuating and they are perpetuated, is what we have to address going into this. Chicago Mayor Lightfoot, who's terrific, has this Invest Southwest strategy, and that's the long-term strategy. And we have to fix this long-term. But in the meantime, we have to respond in the immediate. So I want to talk to you about just some responses, because the mayor, frankly, came to West Side United and said, "What do we do?" Because we had structured ourselves in a way to take on, see how white institutions like mine can begin to make amends, or I call it repair or restore. So one of the things we're doing in the epidemic is we've made a decision that every healthcare provider in the city has to reach out to their patients who are over 65, and then we're going to do 60 to 65. And in a systematic way. So not wait for the patients to show up, because we've earned the mistrust over years. People feel mistrustful of their institutions. They don't believe, with good reason, that we're there necessarily to take care of them, and to call out and reach out to everybody, and to do a few things. One is a check-in. And how are you doing? And you know about COVID, and you know how to keep yourself safe. Number two, screening for social needs. What we found in our own screening is that 40% of our Medicare patients do not have a primary care provider, and the number one social need is hunger. Screen and address social needs as an institute. And then three, figure out a medical check-in in a systematic way. Do you need a blood pressure cuff? Do you need your meds mailed to your house? But we've made this is going to be across the city, starting with Black patients and brown patients from our highest risk zip codes, and then working down your list. Because equity demands that we start with those who need more in the beginning, and then partnering with community-based organizations to do check-ins and deliver food and other things, PPE and other things, while we're addressing disparity in testing availability and then contact tracing. You cannot ask someone who's living in a crowded housing to social distance. That is a middle class privilege, and so we've got to. So how do we actually help people manage in these moments? There's more to this that's going on. Young people, communication, and figuring out how do we get young people around the table who feel hopeless, don't feel the world is looking out for them at all, and how do we get them engaged in thinking about this? So leveraging social media, and these are our community leaders who are leading these kind of action-oriented efforts. So, we have to dismantle this system. It has to be in public policy over time that dismantles racism and obviously, I would say, the aspects of capitalism that exploit people and afflict them in poverty. But in the meantime, these sorts of integrated responses are necessary.
Let me turn to you, Ron. I think in the chat there, folks are looking for any examples. And I was thinking that leadership here is clearly an area that you're very involved in. And when we were planning, well, everyone is, of course, demonstrating leadership on the program. When we were planning it, Derek asked, is there a way to start thinking about this and commitments that we're not going to suddenly slide back from? Do we have such a moment right now? And if not, what would create it? Maybe with your leadership lens, Ron. Thanks. Yeah, great. Whoops. Yeah, there you are.
Okay. Yeah. Well, I think when you ask about examples, I'm not really sure what the caller is asking about examples of. But I would say that building, following my earlier theme about partnering and collaborating, taking on issues of food deserts, addressing transportation issues, using technology investments and solutions like telehealth and others to bring care to where people are rather than put the burden of transportation and getting to your facilities there, to build medical centers from bringing the point David brought in earlier about bringing capital into communities by saying we have to build and renew and upgrade medical centers in our hospitals. Why aren't we building those in challenged communities and bringing economic opportunity, jobs to individuals? And we're a large healthcare organization that uses billions of dollars of supplies every year. So do we have an intentional framework and practice of making sure women and minority-owned small businesses are available through contracts or subcontracting to have access to those dollars to build their businesses up, their economic engines? And so as they grow, they hire more people, they invest in their community, so you create a virtuous cycle. So there are lots of examples of how big institutions in communities, hospital systems, and carrying out their business and operations can partner and collaborate with folks who are part of the community and who represent the disparity or the diversity of the community at all different dimensions. But the point I want to just touch base on as we move to begin to wrap things up is in Derek's blog, one of the questions he raises is what is the health profession? What is medicine going to do, medical leadership going to do currently and coming out of this pandemic? And is this organization, is this institution, is this profession going to lead? You know, we take this oath about doing no harm and allowing no suffering. When we see the devastation and the disproportionality of injury, of death, of suffering, and we maintain as a profession what Du Bois also referred to as this peculiar indifference that he referenced years ago. What is that all about? And what is it going to take to break through to our core missions and values and the oath that we take as to why our profession exists? And I believe, though, that the battle for people's hearts and minds obviously needs to continue from a moral standpoint. But at the end of the day, it's about behaviors and actions. And why can't the healthcare as an institution, hospitals, why can't we build this into the framework of what quality is? And so accrediting bodies that have to accredit hospitals and so forth, if these were standards that were built into the fabric of accountability and the definition of modern medicine, then even if organizations didn't have the benefit of enlightened leadership, they would have to account for their results that would impact their compensation or their accreditation status, that this is quality, this is what health really is in the 21st century, and to do less than that is not acceptable. You got to put some teeth in this that makes people accountable, because if we wait for their hearts and minds to understand this and do it on a sustainable basis, we get the perpetuation of the scenarios we have right now and another missed opportunity to move this to another level. So I think it's about standards that people have to follow, and accreditation in their day-to-day work, a definition of quality that has to be instilled and integrated as part of this. And then it's embracing the people that you are serving. And again, where we are witnessing the damage and the problems, that is the source of solutions. You have to be humble enough and insightful enough and humanitarian enough to engage and understand that people can help you provide solutions if you give them the opportunity and can listen and carry through.
What do you think, Tony? Thank you, Ron. Tony, and then David as well. Go right ahead. Thank you, Ron.
Sure.
Great provocations. Appreciate
I'm
it.
like, let me jump in here. I want to talk about politics. And look, I know all the statuses, C3, C4, all the things, been in there. But like, I'm gonna drop two resources. One is there's this wonderful blog called Nonprofit AF that dropped an article earlier this month that said this is a wake up call for nonprofits and foundations to get political. Because if anyone on this call within the sound of my voice thinks that we're not in this situation because of some toxic politics nationally and globally, then the data won't help you. You know what I'm saying? Like, there's a whole situation. So figure out how to get engaged, because it's really it's the where we are right now. Is well, I don't have to, you all can finish that sentence for me in terms of the politics of what we need to do. I love the blog because it helps us kind of figure out where we are in terms of why our structures have prohibited it. But like now it's so clearly in the way. I would say look at Dr. Brittany Cooper's recent discussions on necropolitics, and that is like the politics of death and like making decisions on who lives and who dies. And let's not really argue about that either. And then the last thing I'm going to say is actually Daniel Dawes, who is the now director of the Satcher Health Leadership Institute at Morehouse School of Medicine, just recently dropped a book on the political determinants of health. So if you want to go that deep into it, please do. But I would say, let's not have an elephant in the room that just mucked this entire thing up and has us even having to have this conversation.
All right. Thank you, Tony. David, maybe some final remarks, then I'll get back to Don and Derek. Thank you.
Maybe three things. Dr. Copeland's note that back in quality and safety, what you inspect, you expect. And so making racial and ethnic data on every quality metric reportable public measures is one way to force institutions to look at data and their gaps, just like we've had to look in this thing. Number two is I can tell you in Chicago, there are academic institutions that would not take transfers of patients from majority black or brown institutions, even with a mayor with a racial equity frame. We weren't one of them, but I know there are some, and it's publicly known. And so structural racism needs to be called out actively. And I'm going to just agree with the last comment. There are political determinants of health, and who has access, who doesn't, and we need to be political in this moment.
Thanks, David. And I think that all the things that each of you has just said underscores kind of the politics of perhaps putting all the emphasis on underlying health conditions or people's exposure to, COVID on their jobs. While that is very huge, there is a whole relationship. In other words, other activities can absolutely take place that can reinforce worse outcomes. So I think it's very important to share even more of these stories of what's going on, even as healthcare, of course, is celebrated for its response. There is no way to wrap up this conversation, and we knew it in planning the show, and we're so grateful to get some wonderful troopers like David and Tony and Ron to join us on this journey that we will indeed keep going with and are very committed to. What I'd like to do is go back now to Derek for a moment, Derek, and one way at least, any thoughts from you, Derek, at all, but one way that we hope to keep some things going with the IHI global health community. Derek?
Yeah, thanks, Madge, and thanks to all our panelists for your just outstanding insight. I'm not really sure how to finish, Madge. I hear a lot that people talk about the system's broken. I don't think the system's broken. We built it this way. We built this. Every system's perfectly designed to get the results it gets, and we built a system perfectly designed to get the results that our panelists have just described. We built the cycle of panic and neglect that Tony referred to. We built the system that creates a 9/11 every year hidden in plain sight that David Ansell talked about. And I guess the only silver lining that I can find is that if we can build that kind of system, we can build a different one. And that's the opportunity that COVID-19 creates. And look, we're not pretending at IHI that we know how to do that. We just have some proposals, some ideas around where to start. And so people who've been looking at this online can see the IHI's health equity framework kind of cycling through. It's a place to start. Please, if you're motivated by listening to this call to start to change the system, to start to redesign the system, then this is a decent place to start. And we'd love to hear about how you get on. In the spirit of hearing about how you get on, we do have this COVID-19 global community that we've set up at IHI. It's a way of engaging in discussions. We do have a section of this that's devoted to equity. And my good colleague and the person who has really led a lot of this work at IHI, Amy Reid, is going to kick off a conversation in the global community immediately following this session. Thank you, Amy, for all you do, but for doing this too. And we hope you'll join. Thanks, Madge. That's all.
All right. Thank you so much, Derek. And I think Don Berwick, you may get the indeed last word today. You're going to be also joining Amy in that conversation. And all these slides are in the deck that people can see. And maybe Vicki can also remind chat people, the link where you can find how to join this and then be part of an ongoing discussion. Don Berwick, there's also the Leadership Alliance, and I'm sure you were sitting on your hands having so much to say, but we appreciate all the listening we all did today too. Don?
Yeah, well, thanks. First, thank you, everybody. The IHI Equity Guide that Derek showed has been one of the most frequently downloaded assets that IHI has ever issued. And the enthusiasm in this conversation shows that there's a reservoir of need out there. Ann Malone and others in the chat were commenting on just the question, how do I get involved as an individual? It's the right question. We need another session on that. One way is to join the COVID-19 global community, and I really hope people will do that. This is going to be one way to bring your concerns and share them with others. IHI's theme is never worry alone. At an institutional level, I want to have an unabashed commercial here. One of the most thrilling projects at IHI is a network. There are 55 member organizations now. This is organizational membership, not individual membership. The IHI Leadership Alliance. It's existed for 6 years. Year 7 is about to start in the fall. This is a tough time for organizations, but please, 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 those of you on the phone who are in a position to do so, please consider joining IHI Leadership Alliance. Topics this important, equity and many, many others come up, and we all do it together. And that alliance of organizations has tremendous power, not just to help the organizations, but to speak out with what we call collective voice on what the changes that are needed. Take Dr. Copeland's suggestion about accreditation, embracing the topic we talked about today. That's something we can speak to collectively as an alliance. So consider joining IHI Leadership Alliance. That's my request. If you need further information, email me, contact us anyway, and we'll get you oriented. Madge, thank you so much for this session.
Yeah, thanks, Don. And the Leadership Alliance has done some very, very interesting things related to equity. Well, huge thank you to Tony Lewis, David Ansel, Ron Copeland, Don Berwick, and Derek Feely. And thank you, audience, for taking the time to participate in this discussion. Please be on the lookout for the archived edition of today's show posted to the website. Make good use of the link. See it as part of your follow-on actions to our discussion today. We'll be back next Friday at 10 a.m. and we're going to just keep pulling these themes through. We're looking again at the near future. Andy Slavitt and Kavita Patel will be our guests, and details soon on our website. It's my honor to host these discussions, even when we run out of time and don't seem to have ever enough time to do justice to all the issues that arise. Make good use of the chat. Spend some time looking at the more detailed bios of our wonderful panelists. You can connect up with each of them. We wish you all the best and good health for the Institute for Healthcare Improvement. I'm Madge Kaplan.